All right, looks like we have a quorum of people, so I think we'll go ahead and get started. Um, just to remind everyone, my name is Elin Zhang. I'm one of the VFM faculty, and I have the pleasure of organizing your grand rounds every month. Today, I have the extreme pleasure of introducing the three co-chairs of the Ethics Advisory Committee, Dr. Mehta, Dr. Marwaha, and Laura Cole. And today, they're going to teach us a little bit about clinical ethics at Valley Medical Center. I'll go ahead and turn over the microphone to them.
Great. Thank you, Dr. Zhang. Thank you, everyone, so much for tuning in. We're really excited that you want to learn more about our ethics committee here at Valley. We'll do quick introductions. My name's Laura. I'm one of the social workers on our palliative care team. I work both in the adult inpatient setting and in our NICU. And I do work primarily as a social worker now, but I also have a Master of Divinity and some training in hospital chaplaincy. And my combination of those fields, social work and spiritual care, have really led me to be interested in ethics as a field. And I've been a clinical ethicist here at Valley on the committee for about 4 years. And I joined as one of the co-chairs last summer. I've undergone the 40 hours of training that we'll tell you a little bit more about later to be one of our consultants here. And I'm really excited to tell you more about our committee. So our other two co-chairs are also going to introduce themselves.
So hi everyone, thanks for joining us. My name is Amisha Mehta. I'm the medical director of the palliative care team. I joined the ethics committee as a co-chair last year around the same time as Laura. I'm not doing consults right now. I'll be undergoing the training, and my hope is really just to have a more robust ethics committee and be doing education like we're doing today.
All right, and I'm Amitoj, I'm one of the cardiologists here, head of the cardiac imaging. So if you have any complaints about echoes or whatever, I'm your guy. And I'm also the co-chair of the ethics committee. I don't know how many years I've been on it. I want to say like 3 or 4. So it's been a while. And I've gone through the summer seminar at the UW, which I think we'll have more information about later.
Great, thanks. And just to let you guys know, we welcome questions throughout the presentation in the Q&A box. We'll kind of all be keeping an eye on it. It's at the bottom of your screen. And then we've also carved aside some time at the end of the presentation to address those questions as well. All right. And Sarah Peterson, she's program manager of palliative care and interim manager of the wound clinic. She's done a lot of work on this presentation as well. She's the one managing the slides. So when I refer to her, that's who I'm talking to. So Sarah, next slide, please. All right, so our objectives today. First, I'm gonna provide just a general introduction to our committee, how consultation works here at Valley, kind of the nuts and bolts. Then Amisha is going to get a little bit more into the ethical principles that we use in the healthcare setting as we do our ethical consultation. And then Amitoj is going to teach you the 4-box method, which is the really structured way we do our analysis. And he's going to run us through an example as well. So what is clinical ethics? A discipline or methodology for considering the ethical implications of medical technologies, policies, treatments, with special attention to determining what ought to be done or not done in the delivery of healthcare. So it differs a little bit from philosophical ethics, organizational ethics, or research ethics in that we're applying these ethical principles to our day-to-day work here in the healthcare setting. The way we're structured here at Valley is that we have 3 co-chairs, and we kind of lead our advisory committee. The advisory committee is interdisciplinary, made up of people from a lot of different fields within our institution, and they provide our general ethical oversight here at Valley. And then a subset of that advisory committee is our ethics consultation service. And those are the trained ethical consultants who are actually the ones responding to and providing the ethical analysis when you put in consults. So a little bit more about our advisory committee. We really strive to make this as multidisciplinary and diverse as possible because we really are committed to getting as many different perspectives as we can in each consultation. That's really important to us. Current disciplines that are represented on the committee are administration, legal and risk, nursing, medicine, social work, and spiritual care. And we're from a lot of different practice settings throughout the hospital. We have community members that are on the committee, cardiology, the ER, hospitalist service, NICU, palliative care, primary care, rehab medicine, and spiritual care. This group meets every other month. I just wanted to note 2 of our co-chairs, myself and Amisha, are from palliative care. We have committee members from palliative care. And I think that our discipline just generally does have a lot of interest in ethics. But I want to make the distinction that ethics is separate from palliative care. It's a separate entity and it does not live in palliative care. Okay. So the responsibility of our ethics advisory committee, there's kind of 3 main roles. The first is to provide oversight and advisement of relevant policies and procedures. Some of the policies currently under the ethics committee are our death with dignity policy, surrogate decision making, and advanced directives. And we're also happy to review new policies or procedures and provide an ethical perspective on them. The second main responsibility of this committee is to provide oversight of the clinical ethics consultations that are being done in the hospital. So every time we do an ethics consult, it is reviewed by the committee so that we can get feedback, make sure that if there's room for improvement, we talk about that, and then just make sure that the quality of consultation here at Valley stays very high. And then the final responsibility is to provide ethics education both to committee members and consultants and also our institution as a whole through things like this grand rounds and other education opportunities. So ethics consultation is a process by which trained ethics consultants who are from the advisory committee respond to requests for help resolving ethical conflicts, issues, or questions involving patient care. The people who provide this consultation have received at least 40 hours of training, and that takes place at what's called Summer Seminar, which is put on by the ethicists up at UW. And I wanted to mention that we're hoping to add more consultants to our hospital. The next training session is this upcoming summer. So if you have a particular interest in ethics, please reach out to us and see if this would be a good fit for you. But also, since we do try and keep this as multidisciplinary as possible, if you're working with some of your colleagues, nurses, social workers, really anyone, and you think that they would be a great person to provide consultation here at Valley, encourage them to reach out to us and express interest. We do get managers' approval, but there's typically a lot of support if somebody is interested in joining the committee. So keep your ears open for people who would be a great fit to go to the training this summer and send them our way. So the main goal of doing ethics consultation at all is just to improve the quality of healthcare through the identification, analysis, and resolution of ethical questions or concerns. And we're hoping that with each consult that we do, the norms and standards that are created will inform the clinical practice beyond that specific consultation. And we're hoping that we're continually working to make Valley Medical Center an ethical place to give and receive care. The way that we try and attain this goal, first, we try to facilitate conflict resolution when the usual strategies have been unsuccessful. Strategies like conferences, family meetings, excellent communication and coordination. If they're just not working, we can help step in. We also want to identify and analyze ethical issues using sound ethical theories and moral reasoning. And Amisha is going to talk to us a little bit more about what some of those theories that we use are. We, again, provide education both through our consultation service and then through things like this so that we're continuing to update our community. And then we also try to address and respond to moral distress within the institution. We know that moral distress is really significant because it leads to burnout and dissatisfaction at work. Especially we've seen that this past year in the setting of COVID. So we hope that our committee can be a place that can help address and alleviate some of that moral distress. Who can request an ethics consultation? So we are available both inpatient and outpatient. Any member of the patient's care team who is involved in their care can request a consultation. Any of the patients with decisional capacity can request the consultation, or their surrogates or family members. And it's just important to note that whoever requests the consultation, the attending physician is always going to be informed when the request has been put in place and will be kept updated throughout the process. When to request a ethics consultation. So we know this is usually what people are most interested in. What are the types of things I can call you guys for? So here's a few different buckets. And for each example, I'm going to give an example of a recent request for consultation that has come into the ethics committee in the last couple of years that kind of exemplifies each of these cases. So the first one is if you have a case that is ethically unusual or very complex. And we were consulted for a patient that was DNR and then ended up receiving CPR. So certainly a very complex situation. The second type of case would be if it's causing significant moral distress for the patient, family, or care provider. An example here that we received was there was a patient that the clinical team was recommending a feeding tube. The patient was unable to demonstrate capacity, and the family made the decision that they did want the patient to undergo this procedure. However, when the procedure was tried, the patient was adamantly refusing treatment, and it was refusing the placement, and it was very distressing to the providers to be trying to put this feeding tube into a patient who didn't want it, even though they didn't have decision-making capacity. So we were consulted for that. The third kind of bucket here is when there is serious ethical disagreement among the healthcare providers or within the patient-family relationship, and it hasn't been resolved through those interventions that we talked about earlier. So an example we received in this category was a mother who was requesting a hysterectomy for her developmentally disabled daughter. And there was just disagreement between the care team and the mother and the patient as to what was ethically permissible in that situation. A fourth bucket is when the patient, family, or healthcare provider wants to discuss important ethical dimensions of the patient's care. So a recent example, we had a urologist, and he requested a consultation just to get some advice regarding a patient of his who had requested a vasectomy. And the reason they were requesting this procedure was because they were a pedophile, even though they were not actively acting on their impulses. And so The urologist wanted to consult with us and just find out what was ethically permissible given this unusual clinical situation. A fifth bucket is when a patient, family member, or healthcare provider needs help navigating an ethically significant decision that needs to be made. So an example of this was we had a homeless patient who lacked decision-making capacity. There was no legal next of kin available, and there were medical decisions that were going to impact this patient's life that needed to be made. So we were consulted for that. And then similarly, decisions about life-sustaining medical treatment for patients who are unable to decide for themselves. An example we have for this was for a cancer patient who was listed as full code. Their treatment team was recommending no further cancer-directed treatment, but the patient lacked decision-making capacity and had no surrogate. So the care team didn't really know how to proceed for this patient. And this is actually the example that Amitoj is going to take us through later in our presentation. So when you put in a request for ethics consultation, what can you expect? So first, we're going to designate a lead consultant, so one of our trained consultants, and they will reach out to the requester as well as review the chart, talk to the attending patient family, anyone else who seems important in the care of the patient, just to gather as much information as possible. The consultant will then help to clarify the source of the conflict, make sure that the ethical question is very clear, and then determine if it can be best addressed through other strategies, which we would help direct you to. Strategies like involving risk management, suggesting a care conference, or potentially consulting palliative care. Or they'll determine if this case is in fact something that would be best addressed by a small group ethics consultation. If it's determined that the ethics consultation is the most appropriate next step, the lead consultant will work with a team and provide ethical analysis using moral theories and reasoning. That team typically consists of the lead ethics consultant, as well as 1 to 3 other trained consultants. And it can also include the patient, family, members of the care team, and representation from subject matter experts like risk and legal. And we really strive for these teams to be as interdisciplinary as possible. So that team is going to provide their ethical analysis, and then they're going to provide a recommendation to the requester. And it's important to note here that it is always still the attending physician who retains final decision-making authority for their patient. What we provide as an ethics consultation service is a recommendation about the ethically permissible options in the case. And both the analysis and our recommendation will be documented in the patient's chart under ethics consult note. And you'll get to see what that looks like when Amitoj presents our example. And then the last of the nuts and bolts here. So to actually request a consultation, you can either email us at ethics@valleymed.org, or we recently also got an order placed in Epic, and it's available to anyone of any role can place an ethics consult through the orders in Epic, and that's for inpatient. We are available Monday through Friday, 8 to 4:30, and we really strive to respond within 1 business day of your request. All of us who are consultants on the committee are doing this in addition to our regular jobs. So while our bandwidth is somewhat limited, we strive really hard to be as responsive and quick as possible because we know that these are really important and often time-sensitive decisions that you're seeking consultation for. If you do happen to put in a consult request outside of typical business hours, we'll respond to you by the following working day. And then just when you're putting in the consult, please include the name and MRN of the patient, and then the reason you're consulting and what your ethical question is. All right, so now Amisha is going to share a little bit more about the principles we use as we undergo ethical analysis.
Thank you, Laura. So ethical choices, minor and major, confront us every day as we're providing care for people with diverse values and just living in a multicultural society. In the face of such diversity, the question is, where can we find moral guides when there's confusion or conflict about what ought to be done? Such guidelines would need to be broadly acceptable among people across many different cultures and beliefs. There's several different ethical principles that seem to be applicable in many clinical situations. And the principles are not considered absolute, but serve more as guides on how to act in clinical medicine. The 4 commonly accepted principles of healthcare ethics include the principle of respect for autonomy, principle of non-maleficence, principle of beneficence, and also justice. So these principles can be applied even in unique circumstances to provide guidance in discovering our moral duties within a certain situation. So let's go through these 4 principles. So the first one is respect for autonomy. So this refers to the right of a patient to retain control over their care and make their decisions independently, intentionally, with understanding and without controlling influences that would mitigate against a free and voluntary act. So this principle is essentially the basis for the practice of informed consent in the provider-patient transaction with regards to healthcare. An example of this is a patient who identifies as a Jehovah's Witness in a life-threatening situation where a blood transfusion is required to save the life of the patient. So the consequences, you guys know, of refusing a blood transfusion may have to be made clear to the patient at the risk of dying from blood loss. Even if the clinician wants to provide a blood transfusion, believing it to be, a clear medical benefit, they, must properly and compassionately inform the patient so that the patient's free to choose whether to accept or refuse the blood transfusion. The next principle we'll go over is the principle of beneficence. So this principle talks about, healthcare providers have a duty to be of a benefit to the patient, as well as to take positive steps to prevent and to remove harm from the patient. These duties are viewed as rational and self-evident and are widely accepted as, the proper goals of medicine. An example here would be a patient comes to the emergency department incapacitated, by an accident or illness. We presume that the reasonable person would want to be treated aggressively, and clinicians rush to provide beneficent intervention, either by, stopping bleeding, mending broken bones, suturing wounds. This is also a situation where the principle of beneficence is given priority over the principle of respect for patient autonomy. The next principle is that of non-maleficence. And this requires of us that we not intentionally create a harm or injury to the patient, either through acts of commission or omission. Basically, we consider it negligent if one imposes a careless or unreasonable risk of harm upon another. This principle affirms the need for medical competence. So medical mistakes may occur. However, this principle, articulates the fundamental commitment on the part of healthcare professionals to protect their patients from harm. An example here is, a patient dying of painful intestinal carcinoma. The patient might choose to forgo CPR in the event of cardiac or respiratory arrest, or the patient might choose to forgo life-sustaining treatment like dialysis. The reason for such a choice is based on the belief of the patient that prolonged living with a painful condition is worse than death. And then lastly, the principle of justice. So justice in healthcare is usually defined as a form of fairness. This implies the fair distribution of goods in society and requires that we look at the role of entitlement. It's generally held that persons who are equals should qualify for equal treatment. An example here is in the case of multiple patients needing an organ transplant. So there are criteria for waiting patient need, including time on the waiting list, severity of illness, and prognostic information. Because of resource scarcity, many patients will die without receiving an organ, and these criteria attempt to distribute the resources as fairly and equally as possible. So now that we've discussed these principles, Amitoj is going to show us how to make them practically applicable in an ethics consult.
All right, thank you, Amisha. So we'll start with basically what's called the 4-box method, which it's a framework developed to take account of the principles and theories and ideals to transfer them from moral philosophy to clinical situations. It was developed in 1982, and it sort of languished for about 25 years or so. But around 2008 or so, that became into literature. It kind of really expanded quite a bit, and it's sort of, I think, it's pretty much the standard of how we go about creating a note and going through these. So the thing to remember is that these aren't rules. They're ways of interpreting the clinical situation in front of you. And it's also important to note, this isn't a scoring system. So it's not like you're checking off boxes and creating a score to come up with an answer. It's more of a way to organize thoughts. So go there. So these are the 4 boxes. So we have, the medical indications, the quality of life, patient preferences, and contextual features. The one thing to remember about these is that while we are concentrating on the patient, we can actually take into account family and possibly also community or societal issues as appropriate. So for the medical indications, we concentrate on the principles of beneficence and non-maleficence. For quality of life, it's beneficence and non-maleficence, as well as respect for autonomy. The patient preferences is for the respect for autonomy, and the contextual features is where we arrive at principles of justice and fairness. The weight of each box and how you kind of determine, the total weight of everything, it comes from the factual circumstances and how they meet the overall goal of the ethical principle relevant to that section. Each case is unique and can be weighed differently, even by different evaluators. So I think it's good to have like a team approach, because what I think may be weighed differently than what Amisha thinks or other people may think as far as each individual box or even just things of the case. One of the main conflict areas may be quality of life. That comes up quite frequently, because what physicians think is a good quality of life versus what patients feel is a good quality of life sometimes don't drive. Patient preferences are always tricky because especially if someone who can't communicate and you may or may not have family members or other people who know the patient well, what their preferences are. The medical indications are usually pretty straightforward, but not always. And the contextual features can be straightforward or varied. Really depends. So, so we can get to our example. So this is a case that came up recently. So it's Mr. Z. And the reason it was attended by medicine cardiology is because I signed the note, and that's how it comes up. So it wasn't anything specific about cardiology. So anyway, Mr. Z is well, you can kind of read. He's a 73-year-old gentleman with decompensated schizophrenia, low extremity weakness, tremulousness, who was admitted and found had a mental status change basically, and had valproate-induced hyperammonemia, which was resolved during the case or during his admission, but at this time he was also diagnosed with metastatic non-small cell lung carcinoma with metastases as well as new cirrhosis. He's also fairly cachectic. So he was, even after we corrected the hyperandrogenemia, he was actually not very verbal, actually essentially nonverbal and not communicative. There was no social support. There was an adult family home he lived at, and there was a director of the adult family home who had worked there for 5 years and said that he had been making his own decisions, although apparently Mr. Z had frequent hallucinations and couldn't hold a normal conversation. So that already became fraught right there. Like, well, how's he making his own decisions if he can't have a normal conversation? But regardless, we had to deal with what we have now. Mr. Z had a son who he had not seen in over 20 years, and no contact information was available at all. He had no other available decision makers for him. So there's a hierarchy of decision makers that is acceptable to the state of Washington, and none of them there was nobody who met any of those criteria. The director of the adult family home could not serve as his decision maker by Washington state law. And I also think he was also not willing to serve as a decision maker, if I recall. The guardianship process was initiated by social work, and a guardian ad litem was eventually appointed, although I believe at the time I was seeing him, it was still in process. He had an extremely poor prognosis, given that Mr. Z does not have medical decision-making capacity, can either consent for palliative care, which I think from a medical standpoint, from what I saw from oncology and from the hospitals, I think everybody agreed that that was the most reasonable choice. His illness was just extremely far gone, and aggressive management wasn't being considered and wasn't thought to be going to be beneficial. But unfortunately, since he didn't have any decision-making capacity, he could not consent to palliative care, nor could anybody, or hospice actually, and nor could anybody make the decision for him. And by default, he was full code. So the question that we had was it appropriate for the team to pursue comfort care while also keeping the patient full code and awaiting an appointment of a guardian, or can they transition Mr. Z to comfort care and start the process of hospice care before a decision maker or guardian was established? Next slide. So here's our 4-box method. So since it's in a note, we have it sort of going top to bottom. So the medical indications, for example, would be he has decompensated paranoid schizophrenia. There's no medical decision maker, or sorry, he doesn't have a decision-making capacity at this time. New diagnosis of non-small cell lung cancer with metastases to the bone, as well as liver cirrhosis of unknown etiology. Extremely poor prognosis, and the most beneficial outcome from a medical standpoint would likely be palliative care for symptom and pain control. Patient preferences, there's a history of incompetence in decision-making capacity. It's unclear, even though the caregiver had stated that he was making his own decisions, it's unclear what decisions he was making. He has no prior advance directives. The oncology team notes he may not have a clear understanding of his disease process. Guardianship has been initiated, but at the time there was no guardian or decision maker, no family to contact. And it was unclear if Mr. Z would want to be full code or accept DR status. His quality of life at present, Mr. Z was about his quality of life. He was fairly nonverbal from what we could gather from the adult family care home that was kind of where his baseline has been recently. He already has metastases to the bone, and his clinical prognosis would probably result in significant pain. Also, Mr. Z appeared to have a poor understanding of the disease process, although, like I said, since he was not very communicative, we're not quite sure. But in any case, he was not really interacting with us. The contextual features, no family is available. The last contact he had with his son was over 20 years ago, and there was no contact available for him. It's unclear about the ability of the nursing facility to take Mr. Z back given his increased level of care. And then the other question is more of a legal one, which is the care team allowed to decide the treatment plan and change code status without a guardian or without someone to make decisions for Mr. Z? So, all right, so the ethics question we had is it ethically permissible to proceed with transitioning Mr. Z to comfort care without a decision maker, or do we continue treatment tailored towards comfort with a full code status until a guardian can be identified? So the key principles we identified here were beneficence and non-maleficence. So it seems ethically persuasive to transition Mr. Z to a code status of DNR comfort and to initiate comfort-focused care, which we could do in the hospital. In a setting of a very poor prognosis with limited or any treatment options that could significantly reverse or improve his medical condition, and based on the principles of beneficence and non-maleficence, the course of action of doing this would provide the most benefit and least harm to Mr. Z. So the recommendations were to initiate palliative/comfort-focused care and transition Mr. Z to a code status of DNR or DNR comfort. The problem is that he can actually proceed to hospice without a decision maker. So in the meantime, the guardian ad litem had been appointed, and then the plan was to discuss with them about the medical plan and ask for an expedited court review in order to provide consent to enroll Mr. Z in a hospice program, which actually occurred fairly quickly. And eventually a guardian was appointed, I believe, within a day, and he was transitioned to a hospice program. One thing I want to point out is a public service announcement, because I get confused, and I'm pretty sure a lot of people get confused what a guardian ad litem is versus a guardian. So the guardian ad litem is a court-appointed representative for the individual, but it's more like someone who will report, investigate, and come back to the court or the judge with information. They're not there to make decisions for the patient. That you need a full guardian to make a decision for the patient. So just a FYI. So, and that was our sample case. I know we kind of went through it quite quickly, but it actually takes a lot longer than we may be implying. So do we have any questions? I believe that's the end of our talk.
Yeah, so feel free to ask us questions about any piece of the presentation, about our case example specifically, or just any general questions you might have. So Dr. Pedroza asked, requests are all through email and not Epic, correct? That is how we used to receive our request for consult, through email. But recently, within the last 2 months, we did get an Epic order put in. So you can request through Epic for ethics consultation. And you just, in your order set, type in ethics consult and it'll pop up. So Dr. Zhang is asking us to go through how we would like consults phrased. And just if we have any additional examples. I think when you're making your initial consult, just giving us the general situation and what you think the ethical conflict is is enough, and then we'll work with you to help narrow down the specific ethics question. And she's asking, should we be discussing them in the context of the 4 basic principles? No, that's not something you need to do. Just give us whatever is concerning you as the requester. It can be pretty general. We use the principles through the analysis, and as the requester, you can often be involved in that process, but it's not something we would expect you to know or consider when you're making the request. So I think, you know, for Amitoj's example, the requester could easily have just said, we have this patient that we need to make decisions about, and there's not a clear decision maker, and we're not sure the best way to proceed. Like something as simple as that is totally fine. And then we help define it into an ethical question that we specifically address. Is that helpful?
That was really helpful. Thank you so much.
So please send us consults, and we look forward to helping.